We're talking about modern EMS and healthcare.
Do we really always need to send a resource? And by resource, the traditional resource being an ambulance. Or do we really just need to help the patient solve whatever problem it is? I loved how the emergency physicians were taking the patient in front of them really from a world of chaos, bringing order to it.
Only 8% of all calls that came into EMS actually were time sensitive.
If I could wave a magic wand or fix anything, it would be to never have to attend a frontline provider's funeral due to suicide or mental illness again.
Well, welcome to another episode of the Leadership Lab, and you're going to start hearing a general theme. We're talking about modern EMS and healthcare, and in studio today, I'm really excited about this. I've got Dr. Troutman, who is the Associate Chief Medical Officer with the largest ambulance service in the United States of America called Global Medical Response. But I'm not going to steal his thunder. I'm going to let you kind of introduce who you are to our audience. Some people may know you. I'm Dr. Troutman, and some may not. I may call you Gerad if you're okay with that.
Absolutely.
It makes it so much
please.
less formal. But introduce yourself to our audience, a little bit about your personal background, and then what you currently do within your current scope.
Absolutely. Well, thank you so much. It's really great to be here and kind of talk about some of the story and journey where EMS is headed and where it should be. So as mentioned, my name's Gerad Troutman, born and raised in Wichita Falls, Texas.
He's a Texan.
I'm a Texan, yep. Guns up. I got to give a shout out to Lubbock, Texas and Texas Tech. So grew up building wrecked cars. That was my career plan, was to be a car rebuilder. I actually still do some of that today. Found myself ended up in college doing night classes due to some local stuff. I, at some point, said, would be interesting to be a doctor. So ended up down that path, got into medical school. And I'll tell you, about a month or so in, I started questioning, why am I here? It just didn't really fit right or seem right. But then I spent a night down in the emergency department and really got a new focus. I loved how the emergency physicians were taking the patient in front of them really from a world of chaos, bringing order to it, providing them the care that they needed. So it really changed my trajectory to focus on emergency medicine. Fast forward a few years, was a new ER doctor, fresh out of residency back in Lubbock, Texas at University Medical Center. And the city of Lubbock needed a new EMS medical director. I was the new guy, so they said, hey, here you go. We need you to do this. I said, what is that? And they said, it's no big deal. You just sign here and you'll get a few $100 a month to do it. I said, sounds fun. Sign me up. Well, I learned real quick, I really loved what EMS could do, and also learned a lot of the problems that our EMS colleagues faced out there. And also is always just kind of frustrating to me about the low acuity patient in the emergency department being responded to by EMS. So then I spent a few years with a couple other physician partners, and we built a few freestanding ERs in Amarillo and Wichita Falls. So I was our CEO and kind of ran those. And then we ended up selling those out. And then I got a phone call from my boss, Dr. Rock, saying,
we love Dr. Rock.
We all love Dr. Rock. I got the best boss in the world.
Yes, you do.
So it was a little over 3 years ago. He said, hey, would you be interested in coming over to GMR full time? So we chatted a bit about some of the mission and vision, very patient-centric, outcome-driven, and we'd like somebody to help lead us on doing stuff a little bit different. So it kind of sums up on where we are today. I can't believe that was a little over 3 years ago now.
Wow, it's hard to believe, Gerad. I do have to say this before we dive into what we're really going to talk about today is if you follow you on social media, you do a lot of traveling. And tell our audience just a little bit about that, because it's the fun part of it. It tells a little bit about your personality.
Yeah, so absolutely, I love to travel. There's so much out there to see, not just in the United States, but obviously abroad as well. But one of the great things with GMR, we're, of course, all over all 50 states. So I do travel to the operations, et cetera. And I always take the time to see the community, whether it's a large community or small community, go out there and do and see what the locals do. I think that keeps me going too, because, traveling at face value is fun, but it's also tough when you're away from home, away from family, but that kind of helps the revive some of that personal why.
And I like that because that's just such a good segue. And I brought that up for a reason because it tells a story. It tells that when you get out there, you also begin to understand and learn the community. And that's who we are in EMS. And that's the modern EMS side is that, a lot of people have been given those stories, Gerad, around that out of all of the fire, EMS and police, there's one that they always let come in, no questions asked. They're not going to ask you where's the warrant or I want to see your badge. They let you in, and that is EMS. And they trust the EMS partners. So let's talk a little bit about what you're doing. There's a lot of great work. And I even had some aha moments, I think a year or so ago, when I was at your headquartered operation, and Ted took me on just a tour of your operations center, which I think was your nurse navigation piece. So talk a little bit about what you guys have been working on doing. Some people may know anecdotally, some people may not really understand, but it was very interesting what you guys are working on and some of the success that we've seen in some of the communities that you serve.
Yeah, absolutely. So across the U.S., we respond to about 1 in 10 911 calls. And so that gives us a unique perspective everywhere from urban to rural to very frontier, both ground and air. We answer that call. So from that perspective, what we see is, do we really always need to send a resource? And by resource, the traditional resource being an ambulance. Or do we really just need to help the patient solve whatever problem it is? Because we want to respect that the patient called 911 for their chaos, their emergency, and it's up to us to respond and do something a little bit differently. And it also really speaks to the fact that EMS is not just transport, and it's not just movement, but it really is providing healthcare. Because the second that second one is dialed, somebody's answering, the healthcare provision has started. And we have, as a profession, have to embrace that. And I believe we are. We're seeing more alignment along that amongst our profession than what I feel like I've seen in the last decade. We're seeing a lot of people come around. And I believe it's partly because the traditional model simply isn't sustainable. We can't add more trucks, add more people, keep doing the same thing. And then the reality is we know the data and the outcomes don't support doing that. And it's really not patient-centric to take a low acuity patient in the back of an ambulance to an emergency department, which, by the way, are also busy and have wall times, whole other discussion there. But let's just solve the patient's need, and let's do it a little bit differently that aligns everything.
I think too, and I'm going to pull some more information out of you, but we did a podcast, I think last week or a few weeks ago with Dr. Beck as well, that they have got, I think he was indicating, and don't quote me on all these numbers, y'all can go watch the podcast, but I think it's around 250, 260 million records over the last 12, 13 years, where they showed that only 8% of all calls that came into EMS actually were time sensitive. So theoretically, the other 92%, you guys are looking at 1 out of every 10 of the calls are coming through the 911 system that may not be time sensitive. They might be urgent or what have you, but there's a different path or modality that they can go through. And this is a program that in your system, I think you guys call this nurse navigation, something like that. So talk a little bit about those that may not know, because some people that listen to this podcast are not in EMS. And so sometimes we get into our group think or into our own silos and we think that everybody thinks. Talk a little bit about that from those that might be dead. What is that type of program when you hear nurse navigation? Some people may think, is that a payer initiative? Is that something? Talk to me about what that is.
Yeah, so whenever you think about nurse navigation from the point of somebody requesting help, if we look across the ponds either direction, this is pretty common. Our other continents, other countries have been doing some type of program for a long time. We've been behind the time because, quite frankly, it's a misalignment of incentive. The way EMS gets paid today is when you get loaded into an ambulance and you go to a hospital. And so there's not been an incentive to do anything any differently. But you pointed out the data point, and I think that helps drive all these discussions. Everything we do in EMS as healthcare should be data-driven. And so we know that there's only a small fraction that really have a potentially life-saving intervention that needs to happen. There's probably another subset that needs an ambulance. But as we look on the other end, and there's also a good paper out about the determinants that are safe to hold. And that's a good starting point where those patients probably can do something other than get in an ambulance and go to an emergency department. So the premise of nurse navigation is take those low acuity patients that have been through the initial 911 screening process that generally is deciding, do I need lights and sirens or do I not? But on that do I not, let's send those to a nurse navigator who uses a physician approved protocol to have a longer discussion with the patient. We spend about 7 to 10 minutes asking a series of questions. The first few are really looking for those red flag symptoms because we know that there are limitations to telephonic screening. We just know that in healthcare in general, and we always want to have that eye on safety. So those first few, if one of those trigger, patients right back for an ALS response. But as we get through those, we get to it's safe to get the patient potentially another resource. That resource might still be an ambulance because sometimes there may be an ambulatory problem. So the patient called because they can't get around and so they got to get to the emergency department. It could be some sort of local clinic, an urgent care or an FQHC. It could be a telehealth connection. And sometimes we also have physician approved essentially advice. Somebody calls in, I ran out of my blood pressure medicine. It's Friday. My doctor's office isn't answering. I feel fine. I don't know what to do. So I called 911. And some people might go, people really call 911 for that? The answer is yes, they do. Absolutely. But in that situation, we can say, you know what? If you have this or this, call 911. Otherwise, call your doctor on Monday and get that sorted out. The other thing we do is we ask that money question, which is weird for EMS, right? Because we treat everyone, and even through the nurse navigation program, everyone gets treated. But we know when it's low acuity, we want to match you not only to what fits your acuity needs, but also what keeps your financial needs in check. So if you're unfunded, you can go to an FQHC and they can work with you on that. If you have private insurance, let's get you to a place that takes your private insurance. And then the last and certainly not least, because a lot of times patients call 911 because they don't have a way to get anywhere. So then we'll leverage rideshare to move the patient from point A to point B, and then also return and also to get a prescription. So that's kind of the program in a nutshell.
I love the concepts, and so I want to further explore that because I think it's really important because we are talking about modern EMS.
Mm-hmm.
And if you've been in the EMS industry for, well, I mean, we're a relatively new industry, so into the 60s, into the 70s, coming out of the funeral home, moving into that piece of it. This is kind of new concepts. I know people are probably listening now, like we keep hearing this. Tell me how many people, because I was very intrigued by the data, because I believe data drives everything right now. And sometimes we get the cart before the horse, and I believe in our gumption and who we are as EMS. I think we've sometimes gotten the cart before the horse with some of this, and we didn't let the data, but we had to bring data. You guys have a lot of data around this program. So talk to me about how much data you have coming in here. Some people are going to be talking about, well, what are the adverse outcomes, Asbel? Have they had anything? You just talked about that. People come through the 911. We always have to. Can you share any of that information? Is it available to share?
Yeah. So kind of a few key points. The program actually started in Washington, D.C. almost 8 years ago. Predated me, but the team says we got the battle scars to learn what worked and what didn't. Then that little thing called COVID happened, so derailed a little bit of growth, or repurposed the growth. But then since then, we've had a lot of growth. So currently in 30-something sites, literally from DC to Seattle, I think 16 different states, constantly active implementations going on. The entire program's had over 250,000 patients through the process. Year to date, and I wish I'd have looked at the exact fresh numbers right now because we have that data. It's updated every 10 minutes, so I could tell you to the 10-minute mark. But almost 60,000 patients year to date. So that's across multiple.
So far this year?
This year,
wow.
Yes. Yeah, and that's from multiple agencies, multiple states, multiple looks of agencies. We know that when you talk about EMS, everybody says, well, if you've seen one EMS, you've seen one EMS. agree with that. So that's some of the fun solve that we've worked through is how do you attach this anywhere? And we're able to do that. But yeah, year to date, almost 60,000 so
So,
far.
so generally speaking, and if you're not comfortable asking this, because I'm going off topic here, because
That's
of
fine.
course we always look at an outline. But generally speaking, when you go into a state or into a city to talk through this construct,
Mhm.
how does the community receive that? Is there something and assurances that you have to give the mayors, the commissioners, whoever you're working with to say, how do we mitigate and prevent any adverse outcomes? How do we look at that? How's that reported back? Can you give a little window into the community on what we're talking about here?
Absolutely. So, look, this is a paradigm shift, right, for everyone, and not just for our first responders answering the call, but to the patients in the community, to the whatever the lawmakers are who's kind of overseeing at some point the level of service of EMS in their community. So we have learned it's very important to meet with all those stakeholders, and also the healthcare environment, the hospitals, clinics, et cetera, those folks, because it's a paradigm shift. This is the way we've been doing things for literally decades. And sometimes off the cuff when people hear, wait a minute, you called 911 and now you're going to an urgent care? That can't be right. So we have to ease their mind a bit. And the data helps that discussion. That we can go through. Like, look, we've learned a lot. We are constantly watching from a QA standpoint. There's various levels to catch potentially a patient. Look at that, just the initial screening process. That in of itself does very good at saying who's safe to hold. But now I've got to a second level of process, and the nurses follow a very scripted, physician approved protocol, but they are nurses. And at any point, if they say, I don't like something I'm hearing, the protocol, I don't like where this is going, they can always upscale that. And, we encourage that. And that's kind of that last piece of safety net to get the patient to where they need to go.
And so I'm going to kind of move into what I enjoy talking about. And generally, if you're watching the Leadership Lab, it's really going to be about healthcare finance, different things related to that. And so let's go to that all important topic. I love it that you talked about earlier is that there's an uncomfortable topic that we talk about with the patient when they come through is like, let's plug them into the right resource to make sure that the outcome for them. And I know my patient advocate friends love that concept that is healthcare really paying attention to what the outcome of the patient is? So if they are uninsured, it's like, well, let's get you referred to an FQHC. Let's get you referred to somewhere where we know there is some type of policy for the indigent, something like that. But more than that, let's go into a different perspective, at a different lens. And this sounds great. This is really good, but the reason why there is a transport model for EMS, because that has been the perverse incentive that has required that from governmental payers and things like that. So I'm going to ask this in a twofold question with you. Getting excited about this, as you can tell, I'm starting to look at is we do have this rural health transformation program. You literally have just come into the studio from dealing with some stuff up in DC as we're working through this. That's kind of been the topic of discussion in our industry, because we're excited that in the Notice of Funding Opportunity, EMS is a core component of how they're going to evaluate the models that states put together. That's another opportunity that we have for us. So let's kind of talk through, in the last 8 years, what you guys have done as I'm calling this, you either protect and preserve or you adapt and innovate. We're an adapt and innovative company, and you guys are adapting and innovating, have been doing this for the last 18 years. Talk me through the funding component of how you guys have been able to organize, if you can. If you can't, that's okay. And then I really want to segue this into, because these are the type of programs that this administration is looking for.
Absolutely. Yeah, so this is the part where I usually like to pull that doctor card and not put on any kind of business hat and say talk to those folks, but certainly happy to chat about this. So the reality is how is nurse navigation funded? Because obviously there's a cost component for the nurses, the structure to have that in place, the leadership, et cetera.
Healthcare is not free.
Yeah,
newsflash alert.
I love that. So the short answer is it depends. There are some places where it's essentially sold as a service. That a municipality may choose to pay so much per group of encounters. That's one option. Sometimes it's built into, if we are the ambulance provider in that area, it could be kind of built into how our financial arrangement is with that community.
It's like a bundled type service then? Okay.
Exactly, yeah. But the point that we need to get to, and I think you're essentially alluding to, is any patient that today, in most places, it dials that second one, there's an ambulance bill generated and there's an ER bill that's generated. That is somebody somewhere's responsibility. That is thousands of dollars. So if I can prevent that, or EMS can prevent that, we should be fairly reimbursed for that.
So I am going to bring up, because I did a podcast several ago. You can go check it out with Dr. Lisa Graybear, who is a healthcare economist. She actually was very, very involved in some of our issues when she did work on Ways and Means. She worked for the Centers for Medicare and Medicaid Innovation, and she did her dissertation, because she's a doctor now as a healthcare economist, on a Medicare Advantage program. But in that point in time, she knows everything about literally a lot about the hospital component. And she made a statement on the record and discussed the point about this. This was where we were, the law had just passed of the One Big Beautiful Bill that had appropriated $50 billion into this rural health transformation program that was supposed to look at rural health care in a transformative way, an innovative way, not doing business like we've always done business for the last 35 to 45 years. And she made a few statements there that I think was the open window, and that I've heard it not just from her, but from so many other people, that CMS has to use the $50 billion differently than what they've used it in the past if they want to achieve a different result. And her suggestion was, with her colleagues, is give the money to EMS, give it to telehealth. Do not give it in the same avenue that you've always given it into, or anything like that. As far as, so she's a champion for that. And I always look for the voices that are outside saying, let's do something different. And to me, this is different. So how do we marry, because there is a discussion in here about how do we take the outcome side, and I've had a lot of conversations with Dr. Beck from ESO and using their outcome data and the longitudinal side of things, but how are you guys marrying that, integrating with what you're doing? Because you guys have a lot of data from this nurse navigation piece. Are you guys doing some things from your perspective? Because I believe data and the clinical side. So I believe people like you, Dr. Troutman, Dr. Beck and ESO and other technology is going to lead this, not the finance folks like me.
Right.
Does that make sense? Like,
yeah, it does.
We're in the back. This needs to be led, because this is all about healthcare and data and outcomes.
Yeah, so great setup. So are we today where I would like to be from an outcome standpoint of nurse navigation patients? No. And what I mean by that is, just currently we're seeing more connection of our EMS data having some hospital outcome, which is a very good thing. Ultimately, what we do on a patient's bedside at their home, how does that change that stay? So we're slowly learning that. We don't have that everywhere as of yet. So we are having those discussions on, well, what about the outcome data from a telehealth provider or from an urgent care system? Because traditionally, we don't really think of that as being germane to the EMS discussion, but obviously now we have a program that it does. So we are talking and collaborating with partners on how do we make that connection, because that really starts to give an entire patient journey picture, right?
You said a key word here called collaboration. And many times in healthcare, and I'm going to pick on my EMS folks, but sometimes we haven't done so well collaborating. And the only way innovation works in healthcare is collaboration. We have to be at the table, and we're starting to see more and more of that. This administration is not afraid. I always keep saying they're not afraid of just blowing it up and starting over again. You're seeing it. Anybody that is still in protect and preserve mode, you do that at your own detriment. Because I actually agree, we've got to do something differently. Some of us have been doing this. How long have you been doing this, Doc?
as far as
just EMS, emergency medicine, healthcare?
14, 15 years post-resident.
14, 15 years. I've been doing this almost 27 years now in healthcare finance only. I don't have the clinical lens, but I've been doing advocacy for 20. There are some of the points that I'm saying right now, I started saying 20 years ago.
Right.
And I'm thinking, this is insanity. I'm not saying this anymore. This is why we're sitting in a podcast now, because I'm done with it. I'm like, let's do something different. One thing I learned from Trump 47 was he went to the podcasters, he got things out there, and things that people never thought were going to happen happened. Whether I agree with them or not doesn't really matter. That's not the topic of this conversation. But healthcare would be wise to rethink.
Mm-hmm.
And we have this new generation coming up, these Gen Zers and Yers and
the youngins
coming up that are thinking differently.
Mm-hmm.
And I've even had to change some of the way that I do some stuff. And so what are a few more things? And I know that you're in a position, I don't want to put you in awkward because it's like, and I agree with you, I'd do the same pivot if I was a clinician. Like, that's the finance folks to deal with. That's not my folks to deal with. But there is some opportunity because, unfortunately, there is a marriage of the two.
Absolutely.
And so how do we engage more of the clinicians like you to really have some of these, what I call responsible conversations, because you guys need to lead this. And we can be there to help you and provide guidance and say, hey, have you thought about this from a policy perspective? It ties to this. But is there a way to continue to keep this movement forward? Because I personally, in the last 6 or 7 months, since I've shifted some things related to, and I learned it all from a marketing company when they introduced StoryBrand to me. When they introduced the concept of StoryBrand to me, being hero and guide, I had so many aha moments a year ago, August. It's been over 14 minutes that I'm like thinking, I can do some things differently now. You've been trying to be the hero. You've been trying to be the hero in your story, Asbel, and is that working for you? And the moment I moved to a guide, it's amazing how quickly and rapidly we're seeing things. So you guys are in prime position. And when I mean you, I'm talking about physicians, you, Dr. Rock, Dr. Beck. I had Dr. Miramonte on here. I had Dr. Victoria Reinhardt that's running the National Association of Integrated Health. She was with me a few days ago. These are the type of things that it's like the same thing, but your voices are all saying the same thing. How can we couple that together? Give me some ideas in your mind. It doesn't really matter. I want to know some of your thought process on that.
Yeah. So certainly I want to comment about collaboration. And I've always personally been a big collaborator and agree it is so important. And having physicians at the table when we're talking about healthcare is extremely important. I think if we've seen the EMS physician as a specialty, people ask, what do I do? I'm not an ER doctor. I'm an EMS doctor. And some people, what is that? This is what that is. It's this collaboration. It's meeting with various stakeholders. It's really trying to come together and solve the problems that allows us to best serve our patients. And you mentioned a number of great folks, and there's hundreds, if not thousands of them across our country.
Hate naming people because when you start doing it,
I know, because
like, why did you name me?
I think all these other names I could throw out there. But, we see organizations like the National Association of EMS Physicians that has just grown leaps and bounds in my decade plus of going to it, that brings the folks together, brings them to the table and discuss. And really, when you look at the EMS physician, kind of the typical person, they're problem solvers, right? They're trying to solve those problems at their local community level, but they start realizing how that's also regional, state, and federal level too. And so I also love the quote of a rising tide floats all boats. And I think that resonates, I know with us as a company at GMR and how we can impact the profession. But I think that resonates with all EMS physicians. If I can learn what somebody's doing with whole blood, there's another great topic. What can I learn from you to maybe do it in my community or see if that's the right thing for me where I am the medical director at?
So let me ask you this question. You just brought up and said, some people ask me, I'm an ER doc, and you're like, no, I'm an EMS physician. I want to unpack that just a bit because that's the first time I've heard that. And I think I know where you're going there, but I don't ever like to think where I think people are going. So explain to me what the unique difference is when I think of an ER doctor And when I think of an EMS doctor or an EMS physician, because some people they're like,
That's
their
true.
medical directors are like, well, they're an ER doctor.
Right.
So talk to me about more than just that collaborating. Can you unpack that just a bit?
Absolutely. So whenever we think about residency training in the United States, you pick a specialty, right? And the vast majority of EMS physicians are emergency physicians as well. So they did the 3 to 4 year residency training to be board certified as an emergency physician. But an EMS physician's a subspecialty training piece. It's a 1 to 2 year fellowship training, just like you can be an internal medicine doc or you can do a fellowship in GI. So then you're a GI doctor. So those of us that have done the training and become board certified in EMS, and I still work ER shifts too back in Lubbock, Texas, and most of us do. I think it's important for EMS physicians to do that because obviously, talking about collaboration, one of the biggest folks we collaborate with are the hospitals we're taking patients to and the emergency physicians so that we can continue to kind of understand that bedside practice of medicine. So the EMS physician training there's a medicine component, but it's a lot more about the operations, the systems of care, the financial piece too of EMS, because there's a financial, operational, and clinical component that really has to marry together. And ultimately, that's driven by the physician, the medical director of that service, really has the ultimate sign off on, is this how we're going to serve the patient's needs?
So I know we've been talking about, thanks for that clarification, because I just learned something new today, and we always should learn something new, because I'm going to probably use that, and I'm going to give you total credit for it, Dr.
Awesome.
Troutman, because I like that ER versus EMS physician piece. That's a great analogy. It's a great story. Let me kind of we talked a little bit about the nurse now, the call that comes into 911, and can it actually be filtered out even before an ambulance? But let's talk about what some people generally know. There's a lot of talk about this treatment in place or this ambulance response, no transport. We talked a lot about community paramedics. I know you were just up, I don't know how much you can divulge from just coming to DC. You were invited into a room of leaders from different states and their governor's administration. But talk a little bit about some of those conversations, what was happening, because there is another avenue here. There's been a lot of people been advocating, for instance, for community paramedicine. That was a big deal. But we went to calling everybody mobile integrated healthcare practitioners. I'm not going to get into all the nomenclature, but generally those same concepts are all there. If you can share just a little bit about that, because to me, this is exciting news. This is great stuff. We've got momentum happening here.
Yeah. So those all ultimately come together. So when we think about like the nurse navigation piece, we know the best operational benefit to the EMS system is what I like to say for the EMS system or the ambulance operations to never know a patient called 911. So if that patient called 911 and I can solve their problem without ever dispatching an ambulance, I've now given unit hour and time back to the system to maybe respond to that gunshot wound or cardiac arrest, et cetera. When we think about the treatment in place, there's limitations to telephonic triage process, right? I mean, we know that exists. I am confident as we tie more data together, we can get better. But at some point, we're humans, we're complex individuals. And so we will never have that dialed in perfect. But now if I have sent a resource, now I have an ambulance on scene, now I've got the benefit of an experienced clinician. I got the benefit of vital signs. I got the benefit of this discussion, the patient-clinician interaction. And so maybe then we can get them care. So we actually do what we call field referrals. So at that point, the field provider can connect to the nurse and say, hey, they met all this criteria. Miss Jones here, it's actually just a sore throat. It kind of sounded like chest pain maybe. That's why we ended up on a response. And Miss Jones is amenable to go into an urgent care. Can you help make that happen? And so then we can take patient and do that and then release EMS so they can answer that next high acuity call. Mobile integrated health, community paramedicine also can become a resource. And usually we think about that. We think of a single person in a SUV or something, right? And you're correct. It's kind of all over the place. Do they have labs with them? Could they have IV antibiotics? Certainly.
Blood.
Well, I think the blood should probably, well, that could be. That's another topic. And I'm a big proponent of whole blood. I know, okay, this isn't a blood talk, but we've been given blood in Lubbock, Texas, where I'm local medical director for over 2 years, and I sit on the national coalition and the Texas task force. Of course, we've got some monies to try to make that happen across the state. But From a vision standpoint, why could we not have a EMS provider go into a home, do an evaluation of the patient, get some oversight with a telehealth doc? The doc goes, you know what, let's get a chemistry and let's give a liter of fluid and some nausea medicine. Call me back in an hour when that's done. And then they call back, well, the labs look good. Miss Jones is feeling better. Made her a peanut butter sandwich. You tolerated that. Okay, cool. Miss Jones, here's kind of the plan, and never have to touch a hospital. That's well within the wheelhouse today, but it's a misaligned incentive still.
And states do a little bit different. Every state does things differently.
Mm-hmm.
So I really like how we've got this entire transformative fund that's happening that is at the state level right now. That to me is where we should have started from beginning, not even down to the local, but at the state level. Because for instance, in Texas, you guys as medical directors are given a lot of authority at the local level, but in some states, it's more governed at the state. It could be a
Very much
regional
so.
a medical society. So talk through, because paramedics all do operate under the scope of an EMS physician.
Mm-hmm.
One way or the other, how the states have it outlined. And I think sometimes people forget about that practice. And there's this discussion happening. Don't mean to put you on the spot because you don't even know this question's coming to you, but it's about to. About having a mid-level practitioner level, like creating EMS as a mid-level practitioner or a paramedic or something as we work into this scope. Have you guys thought about that? Have you personally thought about that from a clinician perspective? I have my own perspective about that if we're really trying to drive down costs, there's a lot of stuff that we can do in our communities. I'm not really sure why we are continuing to advocate for this at this point. And please don't shoot me if you're listening to this today or turn. But my stand was I think we need to have those discussions, if that makes sense.
Yeah, ultimately, and I don't know all the details about the mid-level practitioner that you mentioned, but I certainly believe that when it comes to caring for a human, that a physician should sit at the top of the care that's being provided. And, maybe not always directly, it could be through delegated practice or what have you, but physicians are physicians, right? I mean, we are the tip of the spear experts on how to care for another human being in need, and they need to lead that care.
So you heard it from Dr. Troutman directly. So if you have another opinion on that, where this is from the physician, this is why I have you guys here.
Mm-hmm.
I think it's really important for us to begin to understand that. As we're winding down, I'm always asking a question here of every guest, and I really want to know that if we could look in our crystal ball. And Doc, you had one thing that you said as I've looked at healthcare since I've left my residency. I've been on this for the last 5-6 years here at GMR, for the last 3 or 4 years working through what we call modern EMS delivery. What would be that one thing? If you had one thing, you could rub the genie in the bottle, out pop the genie, and I could say they would give you anything you asked for. What would it be?
So actually, I think that's a pretty easy response.
Okay.
It kind of mentioned that today, EMS, we go into somebody's lives when they're having chaos and we bring order to it. The problem is over time, our frontline providers who may have order in their lives, sometimes that brings chaos. And mental health is a problem across all of our frontline providers. And I think if I could wave a magic wand or fix anything, it would be to never have to attend a frontline provider's funeral due to suicide or mental illness again.
Wow. How sobering. Wow. That's, yeah. Thank you. Thank you for that. And the people that are listening today, that we didn't have to have one more of our comrades that are on the front lines that would ever have to deal with that again. One last question that I'm going to leave our audience with. And I really want this to be from your perspective, Doc, and what you do in leading as the Associate Chief Medical Officer for the largest ambulance service in the nation called Global Medical Response, is what can our industry do over the next 6 months to ensure that as these innovative ideas are continuing to happen, we have been talking about wanting to get this done, and sometimes we unfortunately can't get out of our own ways because our egos get involved just like anybody else does, is as the largest ambulance service, it goes without saying, you guys are going to have an ego. That just is a natural thing. Anybody that's the largest, we generally have egos. But what are you guys doing? What are you doing personally from your advocacy? I see it personally. I can probably give you my perspective of what I think you are doing, and that's why I brought it out. I think you're doing some great work and sharing the personal side of what have you. But what are you intentionally doing to bring this together to say, guys, we have an opportunity. Let's try it.
So first and foremost, and we already talked a little bit, is collaboration. And whether that's, at a local, regional, state organization, whether it's National Association of EMS Physicians, whether it's the American Ambulance Association, being a collaborative part of those tables and having those ongoing discussions, because ultimately we're all looking at the same thing. It's all about the patient. The other thing I think as an industry we got to be careful about is the what ifs, because everybody has that story, right? And because this is sometimes we get the naysayers. They go, but I remember a patient with knee pain and I got there, they were in cardiac arrest. And we don't want that to happen ever, right? And that's where we dive into the data and try to let data drive, but don't let the what ifs derail what is really best for all of America, right? Because if we do that, I've said it before. I said, why don't we build a hospital and fill it full of ER docs on every single corner? Level 1 trauma center, comprehensive stroke center, every single corner of America. And guess what? People will probably have better outcomes, but come on, that's in no way sustainable. So how do we do what we can in the most safest, data-driven way, patient-centric, with what we have out there, collaboratively and all together?
I'm going to leave it at that because I want that to resonate. If we will rewind, I'm going to actually do a reel just on that piece, because that to me is the reason why there is an unsustainable rise in cost in healthcare. Forget EMS, in healthcare. Dr. Troutman, thanks for coming today and joining the call. Excited about this podcast. Excited what you guys are continuing to do and keep leading forward.
Thank you so much. Really enjoyed to get to chat today.
Absolutely.